A 67-year-old woman comes to the emergency department 60 minutes after sudden onset of shortness of breath. She she also had 2 day she also had 2 day history of swelling of her abdominal legs. She received the diagnosis of carcinoma of the right breast 6 years ago and underwent lumpectomy followed by radiotherapy and chemotherapy. She has type 2 diabetes mellitus, well controlled with diet. On arrival, she is in severe respiratory distress. Her pulse is 122 per minute, respiration 28 per minute, blood pressure 94 by 60, pulse oximetry on room air show oxygen saturation is 88%. Examination shows jugular venous distension. Heart's examination shows jugular venous distension, heart sound at distance. A pericardial valve is heard best at the second to fourth left intercostal space. The abdomen is distended and non-tender. The liver is enlarged. There is 2 plus edema of the lower extremity, and X-ray shows sinus tachycardia, sinus tachycardia and ST segment elevation throughout all leads. An X-ray of the chest is shown. Which of, which of the following is the most appropriate next step in the diagnosis?
What is it? Is it
Is it
MPPV?
sorry?
Oh,
Is it pericardial effusion or tamponade?
yeah, one of the two. But do you is it MPPV or do you do intubation? The saturation is 88. Pretty low. Okay, I don't know. Ready? I know it's one of the two. I just don't know which one.
You were talking, isn't it like
Uh huh.
ultrasonography and really just removing the fluid if it is tamponade?
Which option is removing the fluid here?
There is no option of removing the fluid, like bedside cardiac ultrasonography for confirmation, and then so you are
Oh,
thinking about non-invasive ventilation,
I'm
or
thinking about oxygen is low, so we should do something with of a shortness of breath. I mean,
yes,
because there is no
that
of course, if there was like removing the fluid, I would have gone with that one. But there is no option like that. I mean, unless you want to say bedside ultrasound is. I mean, I don't
okay. Let's see.
know. Oh, you
I am right. Yes,
yes,
I am stick to my point.
yes. You,
Really,
yeah,
I
that,
give that answer.
yeah. Don't that at this point don't change because I'm bad at emergency. But this one I don't
No,
change.
no, it's not
That's right.
like my thing makes sense. That's why it happens. But your
Mm,
thing's also correct. Like a
yeah,
patient
no,
saturation is declining, so why we should not give like
yeah.
NIVP? Okay, let's see.
Bed- Bedside ultrasound is the most appropriate next step. This patient has history of breast cancer and now presents with tachycardia, JVD, pulmonary edema, hypertension, pericardial hepatosplenomegaly, ST, elevation. Together is concerning of pericardial tamponade, likely secondary to malignancy. Further assessment with bedside ultrasound should be next. Characteristic findings on echo include pericardial effusion, um, collapse of the right atrium at the end of diastole, and a collapse of the right ventricle in the early part of diastole. It additionally causes paradoxal, which is a clinical finding defined by the drop in systolic BP of greater than 10 with inspiration can also be visualized on echo as changes in the volume of the left and right ventricle with expiration. Okay. As a result of increased diastolic filling pressures and equalization of diastolic pressures between the left and right heart, other potential findings include congestive hepatopathy and tender hepatomegaly from flow reversal within the hepatic veins and pulmonary edema. So bedside cardiac ultrasound is the same thing as echo.
Yes.
Okay. And non-invasive ventilation with bilevel blah 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 is sometimes used in patients with acute heart failure and pulmonary edema. This patient pulmonary is likely to improve with treatment of a pericardial effusion. Orotracheal intubation is reserved for patients who are unable to protect their airways as a result of their mental status or for those with respiratory failure. This patient is awake and talking and does not require intubation. She's awake and talking. Okay. Okay, next.
Yes. A 14-month-old girl is brought to the emergency department 20 minutes after having a generalized tonic-clonic seizure at home. The seizure begins after she awoke from a nap and lasted approximately 3 minutes. She was drowsy afterward. This morning, her parents noted that she had mild rhinorrhea. She was born at term following an uncomplicated pregnancy and delivery. Development has been appropriate for age. On examination, she is alert and responsive. Her temperature is 39.8 degrees Celsius, 103.6 Fahrenheit, pulse 140 per minute, respiration 24 per minute, blood pressure 90 by 60. There are copious nasal secretion. There are copious nasal secretion. The neck is supple. The lungs are clear to auscultation. Muscle strength is normal. Which of the following is the most appropriate next step in the management of this patient seizure?
Ready?
1 second, please.
Mhm.
Okay, ready?
Yes. So it is the assurance. This infant generalized seizure, which occurred in the setting of fever, upper respiratory illness, is consistent with diagnosis of simple febrile seizure. Febrile seizures typically occur in children 6 months to 6 years and may be simple, which is generalized, lasting less than 15 minutes, or complex, which is focal, recurrent, or lasting more than 15 minutes. Majority of febrile seizures are simple and neither require treatment or carry a significant risk of future epilepsy. Careful history of physical exam are necessary to distinguish febrile seizure from complex seizure resulting from viral or bacterial CNS infection. Now, CT scan of the head is useful for identifying an intracranial mass lesion or hemorrhage. This chart does not display focal neurologic signs or other mental status to suggest an underlying intracranial pathology. Yeah. Next.
Yes. A 70-year-old woman is brought to the emergency department by her family because of one day history of intermittent agitation and confusion. During the past 2 days, she has had a cough and has felt cold. She has hypertension, coronary artery disease, Graves' disease, She takes lisinopril, methimazole, lovastatin. She has no known allergy. On arrival, she is oriented to person but not the place or time. Her temperature is 103 degree Fahrenheit, pulse 150 per minute, regular respiration 26 per minute, blood pressure is 114 by 52 millimeter of mercury, pulse oximetry on room air shows oxygen saturation 92%. The skin is warm, moist to touch. Cardiac examination shows no murmur or gallop. Bronchi are hard in the right lung base. The abdomen is soft and non-tender. Cranial nerves and motor function, sensation, and the cerebellar function appear to be intact, but patient agitation prevents a detailed neurologic examination. Plantar reflex artery plus bilateral. In addition to the X-ray of the chest, which of the following to confirm the diagnosis?
Ready?
1 second, please.
Mhm.
Okay.
So is thyroid function testing. Thyroid storm serious potential complication. Hyperthyroidism. It typically occurs in patients with non-diagnosis of hyperthyroidism following physiologic stress, surgery, or trauma, or in the setting of infection such as this patient who presents with signs and symptoms of pneumonia. Signs and symptoms of thyroid storm include hyperthermia, tachycardia, tachypnea, hypertension, diaphoresis, agitation, tremor, hyperreflexia, nausea, diarrhea. It may progress to higher portal failure, obtundation, seizure, coma. Initial diagnosis of thyroid storm is made for a combination of clinical features and thyroid function tests, which shows increased T3, T4, and decreased TSH. Management requires supportive care, treatment of the underlying stress, and as well as IV steroids, beta blockers, PTO, and potassium iodide. It is not, I want to read the other one. That's how it is. Blood culture is an appropriate step for diagnosis of bacteremia and sepsis. This patient had mental static hypertension and no grace is more concerning for thyroid storm. CBC may discuss neutropenia in the setting of pneumonia. Um, these findings are relatively not specific. The CT scan is useful for excluding the presence of intracranial mass prior to performing a lumbar puncture or in patients with meningitis. Meningitis with fever, headache, photophobia, phonophobia, and neck stiffness. Yeah, all right. Next.
Yes. Acetaminophen and 0.9% sodium chloride, 0.9% saline 2 liter are administered, and supplemental oxygen via nasal cannula is initiated. 1 hour later, her temperature is 38.2, 100, pulse is 145 per minute. Are you there?
Yeah.
I don't know. Your connection is lost. I think so.
Can you hear me?
Yes, I can hear you now.
What do you say? eh, What do you mean my connection is lost?
Like, it, the sound of ringing comes. Okay, now
Ah.
it's all right.
Oh.
Let's study.
Okay.
Acetaminophen and 0.9% sodium chloride 2 liter are administered and supplemental oxygen via nasal cannula is initiated 1 hour later. His temperature is 100.8 degree Fahrenheit, pulse for 145 per minute. Respiration 22 per minute. Blood pressure 135 by 65 millimeter of mercury. Oxygen saturation 97%. Lab study shows leukocyte count 17,000. Segmental neutrophil 85%. Bands 3%. Lymphocyte 10%. Monocyte 2%. Sodium 145. Creatinine 1.3. TSH 0.01. Lactic acid 2.4. X-ray of the chest are shown in addition to the antibiotic. The most appropriate next step in the management of the administration of this patient's following.
Ready?
Yes,
Is propanol or thyroid storm can be urgently life-threatening uh, by causing tachyarrhythmia, MI, high power failure, and circulatory collapse. Rapid treatment of vital sign instability is the utmost importance and includes treatment with adrenergic blockers. Beta blockers are useful for the management of food heart failure, having antithyroid effects. Like hyperthermia and hypotension are treated with antipyretics and cooling. uh, and with fluid resuscitation. Patients with thyroid storm require intensive support, typically in an ICU. Once vital signs are stable, further treatment typically requires antithyroid medication, so that's PTU. Next,
yes. An 18-year-old girl is brought to the emergency department because of 6 hour history of fever, headache, neck pain, back pain, fever, headache, neck pain. He appears acutely ill and lethargy. His temperature is 34 per 100. His temperature is 30 degrees Celsius, 104 degree Fahrenheit. When he attempts to flex his neck, he has severe neck pain and automaticity of the flex his legs. Explanation of small petechial hemorrhage on the abdomen and thigh. He is oriented to person but not the place and time. Cerebrovascular fluid in analysis to show which of the following.
ready?
1 second. Is it Neisseria meningitis?
Probably, yeah.
Okay.
So is E, letter E. This patient demonstrates findings of acute meningitis, but meningococcal meningitis, including fever, headache, neck stiffness, rash. This patient also demonstrates Buzinski's.
Hello?
Infections may be seen among
Hello,
young
hello,
adults.
hello.
Can you hear me?
Now I can hear you. I don't know.
That's
Uh, uh,
weird.
like you are reading, then something your calling sound is, I can hear your call sound, then you start reading like that.
What? Okay, let me call you back. I don't know if it's my thing. That's weird.
Okay.
Bit low.
I don't know what is happening.
Okay, now. Maybe I don't know. Maybe it's the way my computer is. I don't know.
No, no, no,
But
maybe not your computer. Today, my network, everything is getting,
exactly.
it's
No,
so maybe my thing.
okay. Let's see. Let me know if it's better now. Where was I? Cluster of infections may be. No, let me start. This patient demonstrates findings of acute meningococcal meningitis, fever, headache, neck stiffness, petechial rash. This patient also demonstrates Brudzinski sign, meningococcal meningitis caused by Neisseria in teenagers and young adults. Cluster of infection be seen in young adults sharing close living quarters like dormitories and barracks. CSF analysis, bacterial meningitis demonstrate leukocytes with neutrophil predominance, increased protein and decreased glucose. The appearance of fluid is cloudy. Additional studies such as gram stain and bacterial culture will often be positive. Thus, the CSF finding in this patient are more clearly show cloudy fluid with leukocyte count 2600 with 70% neutrophils, increased protein and decreased glucose. Is it better?
Yes, it's better now.
Okay, perfect.
Next.
Yeah.
A 42-year-old woman comes to the emergency department because of 2-day history of moderate intermittent right upper quadrant, intermittent right upper abdominal pain radiates to her shoulder blade. The pain typically occurs 40 minutes after eating and is associated with nausea and vomiting. She says that she has not eaten much today, but she has not eaten much today, but continues to have pain. She also have temperature 101 degree Fahrenheit. She has no history of similar symptoms. She has mild asthma treated with albuterol inhaler as needed. She has no history of operative procedure, has no known drug allergy. His current temperature is 38.1, pulse 92 per minute, respiration 16 per minute, blood pressure 136 by 72, pulse oximetry on room air shows oxygen saturation 100%. The abdomen is soft. There is no tenderness to palpation. There is no tenderness to palpation to the right upper quadrant. The patient ceases respiration during palpation of the right upper quadrant. The patient ceases inspiration during palpation of the right upper quadrant. Hematocrit 38, leukocyte count 13,000, platelet 2 lakh 84,000, serum 134, potassium 3.5, bicarbonate 21, hemoglobin 2.8, direct is 1.2 AST, AST 243, AST is higher than the ALT, lipase is normal, immunolysis show no abnormal feature. The following is the most appropriate next step. It is acute cholecystitis, isn't it?
Mm, mm, acute cholecystitis, acute cholecystitis. Yeah. Um. Hmm. Why is the ASDLT high? Doesn't make. I mean, I guess.
Are you there?
Yes. Ready?
Yes.
Uh,
Ready.
yeah. Let's see you. Yeah. Acute cholecystitis occurs secondary to obstruction of the cystic duct from gallstone, which results in subsequent inflammation of gallbladder. These factors for development include female gender, multiparity, increased age, obesity. High rates of gallstone formation are also seen after periods of rapid weight loss. Don't make it. Yeah. Acute cholecystitis typically presents with fever, abdominal pain, tenderness to palpation right of the quadrant. Often in patients with history of biliary cholecystitiasis, the pain may also radiate to the right shoulder or in the scapular region. It may be distinguished from biliary colic by its constant rather than intermittent nature and associated with findings of fever leukocytosis. Abdominal ultrasound is the first line. Um, Characteristic ultrasound findings, acute cholecystitis, gallbladder wall thickening, hyperemia, pericholecystic free presence of gallstones, dilated cystic duct or common bile duct, and sonography marking sign pain with compression directly over the gallbladder. Treatment is supportive therapy, IV fluids, IV antibiotic, urgent surgical resection of the gallbladder, cholecystectomy. IV antibiotics therapy should cover gram-negative growths and anaerobes, making piperacillin enterobactam the most effective. Okay. Next.
Yes. A 78-year-old woman. A 78-year-old woman is brought to the emergency department by paramedics because of 1 day history of generalized weakness and confusion. Medical history includes mild dementia, hypertension, osteoporosis, medications are alendronate. Medications are alendronate or donepezil. On arrival, the patient appears ill. She is oriented to person but not the place of time. His temperature is 35, pulse 128 per minute, respiration 22 per minute, blood pressure 76 by 50. The remainder of the examination shows no abnormal leukocyte status 2 plus WBC 50 to 100 high power field and RBC 10 to 20 high power field. A central venous catheter is inserted within the patient is lying. Ceftriaxone and 0.9% sodium chloride are administered during the first hour after fluid resuscitation. Central venous catheter pressure is 2 mm of mercury. Which of the following is the explanation of this finding?
Mm, what is happening?
CVP is normal central venous pressure, isn't it?
It's kind of normal low. So what are they trying to say? That
If
I'm
you think
between the
about the shock box, there is hypotension. Okay. Which
I
what
don't
kind of
think she
shock?
has shock. Does she have shock?
Yes, blood pressure is low,
Blood
tachycardia.
pressure, blood pressure is low. Okay, blood pressure is low.
So now
So
we
you
need
think
to find out what kind of shock. Is there any volume loss?
I don't think this is the reason is the shock that she's they said they gave her fluid. So
Yes.
what they are assuming that the CVP should go up if they gave her fluid. So the CVP didn't go up. Oh, so you think they're trying to say, okay, that doesn't make sense. I don't understand. Okay, maybe it's improper placement. No. You think it's anaphylaxis? No, but anaphylaxis, I feel like she will have other things.
In
I don't know.
anaphylactic shock, sepsis and anaphylactic shock. Sepsis, the extremity should be warm. There may be fever.
Here
And
the it's
yes,
pretty low. Here the
so
temperature is pretty
very low.
low.
So hypothermic. So it is not septic shock.
But I
And
thought septic can also come with low temperature. There was a question where we maybe not. I don't know. I don't know. Maybe not. Maybe not. But septic wouldn't. It wouldn't. If you give IV fluid, it doesn't work.
it doesn't work
It
because
doesn't work.
comes with septicemia, you need antibiotic.
They gave her ceftriaxone.
But ceftriaxone is not helping, does it?
Oh no. Okay, just pick something. I think it's improper. Maybe they placed the thing wrong. I don't know. Ready? This is weird. Ready? Sorry, I can't hear you.
Yes, ready.
Oh, it's septic. Never mind. This
You are
patient
right.
demonstrates. No, no, no. It's I pray I didn't pick septic. This
Okay.
patient demonstrates persistently decreased CVP despite fluid resuscitation, which is suggestive of vasodilation by septic shock. The third, I don't know what is this. Define septic shock by a vasopressor requirement to maintain mean arterial pressure greater than 65 or serum lactate concentration greater than 2 despite fluid resuscitation. Okay, so this international council, whatever, defines septic shock by a vasopressor requirement to maintain the mean arterial pressure greater than 65. So it needs vasopressor or serum lactate concentration greater than 2, despite fluid resuscitation. This patient presents with finding concerning of UTI as a source of urinalysis, whatever. This is likely caused by the patient's probably bacteremia and sepsis. Um, which predispose her to develop septic shock. Septic shock is characterized by profound circulatory dysregulation, causing abnormal peripheral vasodilation, which result in decreased systemic vascular resistance, decreased mean arterial pressure, and consequent organ hypoperfusion and dysfunction. It's not dehydration is unlikely to in this patient whose CBP did not respond to saline. Refractory hypotension in a patient who has been adequately volume resuscitated is concerning for septic shock, especially in the setting of other signs and symptoms that are suggestive of infection and sepsis, such as hypothermia or fever, tachycardia, tachypnea, pyuria. Improper placement of the CVP is unlikely given the successful administration of antibiotic and fluids. This patient refractory hypotension is more concerning for septic shock than misplaced whatever. Okay, so the key here is septic shock doesn't resolve with administration of fluid. You have to give vasopressor. Yeah. And I guess septic shock can come with hypothermia too. Next.
Okay. A 66-year-old woman is brought to the emergency department from the skilled nursing facility because of 1 day history of shortness of breath. Staff noted that her breathing has been more labored since yesterday. Earlier today, on room air da, pulse oximetry on room air done as a routine vital sign assessment showed an oxygen saturation 88%. He has moderate obesity, hypertension, type 2 diabetes, myocarditis, and coronary artery disease, obstructive sleep apnea, and dementia. Medical history: propranolol, metoprolol, amlodipine, oxygen via pulse oximetry show 6 liter per hour supplemental oxygen by nasal cannula. Auscultation of the lung discloses diminished breath sound, shallow respiration, cardiac X-ray, tachycardic, normal breath sound. Okay, by level cardiovascular began on the arrival of the. Okay, pH is very low, PCO2 is very high, oxygen is low, and bicarbonate is higher. Okay, ready?
Mm, mm, mm. One moment. Yes, ready. Is intubate the patient. This patient is presenting with shortness of breath and shallow respiration with associated hypercardic respiratory failure as seen on arterial broadcast. This patient likely has underlying of obstructive lung disease secondary to obstructive sleep apnea or obesity hypoventilation as evidenced by the increased bicarb indicating a compensatory metabolic alkalosis in the setting of respiratory acid. Nevertheless, and regardless of the reason of the derangement, this patient hypercarbia is severe, and chronic, acute on chronic, and causing persistent respiratory acidosis, as as evidenced by decreased pH in spite of NPPB and appropriate corrective measure. Percarbia is the most likely underlying cause of the patient decreased level of functioning and is likely compounding baseline from dementia. Number eight. From dementia. MPPB is often the first step in management of precardial respiratory failure, but it's insufficient in this case. But if it's insufficient in this case, with continual attainment of statin and severe acidosis, the tracheal intubation to protect the airway and facilitate invasive positive blah, 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 pressure ventilation is necessary. Next.
Yes. A 53-year-old woman comes to the emergency department because of two episodes of dark brown emesis during the past 4 hours. She has taken ibuprofen daily during the past 2 weeks because of chronic intermittent low back pain. She has, sorry, I'm reading the question again. Okay. A 53-year-old woman comes to the emergency department because of two episodes of dark brown emesis during the past 4 hours. She has taken ibuprofen during the past 2 weeks because of chronic intermittent low back pain. She has no history of illness, takes no medication, does not take any other medication. She has no known allergy. She drinks 2 to 3 glasses of wine daily. She has smoked one pack of cigarette daily for the past 30 years. Her temperature is 36.6, pulse 116 per minute, respiration for 18 per minute, blood pressure 92 by 54, pulse oximetry on room air, oxygen saturation is 97%. Lungs are clear to oscillation, abdomen is soft, and there is mild tenderness to palpation over the epigastric region. Which of the following is the most appropriate next step in a management?
Ready?
Yes, ready, ready, ready.
Is administration. Yeah, is administration of saline. Gastritis classically presents with left upper quadrant or epigastric pain, nausea, vomiting. If erosive gastritis or an ulcer is present, meses may be blood sweat, frankly blood or coffee ground. If bleeding has been present for several hours, stool may be melanotic, so melena. Gastritis commonly occurs from alcohol use, abuse, excess use of NSAIDs, steroids, infection, smoking, other causes of upper GI bleeding include esophagitis, esophageal varices, peptic ulcer disease, AV malformations. Regardless of the cause of any patient presenting with tachycardia, dry mucous membrane, signs of hemorrhagic shock, such as this patient with hypertension, should receive immediate IV fluid. typically with isotonic whatever, massive hematemesis, persistent hemodynamic instability, or concern for active bleeding should prompt emergent blood transfusion. It's not omeprazole. PPI is the first line pharmacotherapy for patients presenting with GERD, reflux esophageal peptic ulcer disease. Why it may be helpful in in the treatment of this patient, the first step of managing a patient who's apoplectic and tachycardic is resuscitation. It is not E. Upper endoscopy is a definitive means of diagnosis and treatment for patients with GI bleeding suspected to come from the esophagus, stomach, or the duodenum. Definitive means of diagnosis. Okay. However, it should take place after full resuscitation and stabilization of the patient's hemodynamics. Okay.
Okay.
Next.
Yes. A 23-year-old woman with a major depressive disorder is brought to the emergency department by paramedics after jumping from a third-story apartment window in a suicide attempt. The first was reported, the fall was witnessed by the patient's girlfriend, who says that he has been dependent since he losing her job. En route the hospital, En route to the hospital, he lost consciousness and backed valve mass ventilation began. A cervical collar is in the place. The patient withdraws to painful stimuli but do not open on eye. Do not open on his eye, but does not open on his eye. His temperature is 36, pulse 100, respiration 7, blood pressure 95/50, respiration 7, blood pressure 95/50, pulse oxygen room near oxygen saturation 96%. Examination shows condition and laceration over the skull. Which of the following is the most appropriate next step in the management?
Ready?
1 second, please.
Okay.
Okay, ready.
So it is orotracheal intubation. The initial evaluation of critical aid patient includes assessing the airway, breathing, circulation, central nervous system, and any external threats to mortality. So A, B, C, I don't know. Airway management should take place prior to further management. In acute trauma, airway and breathing must be managed before circulation and CNS lesion. A patient with compromised airway and insufficient respiratory drive is immediate risk of death. Example of airway compromise include facial or neck trauma, airway foreign bodies, expanded neck hematomas, uncontrolled vomiting, loss of airway protective reflex, arterial metastasis. Orotracheal intubation and ventilation is the most appropriate next step for this patient with a depressed Glasgow coma score, bradypnea, and obtubation and coma. Now, CT scan of the head will be critical in the diagnosis and management of this patient head trauma. However, any diagnostic image should be performed after evaluation and management of airway breathing circulation. Determination of the GCS score is a part of primary survey after ABCs. While GCS score can help determine the need for intubation, this patient will already require airway management caused by decreased respiratory rate and altered mental status. Okay, next.
Okay, let's take a break. Have you done your